Today's topic is otitis externa. Let's dig. Otitis externa, from the name, otitis means inflammation of the ear, externa means external. This is also called the swimmer's ear, and this is the inflammation or the infection of the external auditory canal. And it's most often caused by local bacterial infection, so it's usually local infection. The risk factors include trauma, use of cotton swab, and ear cuddling. They also include skin conditions such as dermatitis. This also includes increased moisture, as I mentioned before, which is also called the swimmer's ear, including swimming, and immunosuppression such as DM and HIV. So immunosuppression will also predispose the patient to a variant of otitis externa called malignant otitis externa. So in addition to that, you can also have foreign bodies such as hearing aids. So the causes of otitis externa can be divided into infective and reactive. So effective, you can have bacteria, and the most common bacteria that causes otitis externa is Pseudomonas aeruginosa. We can also have Staph aureus. In terms of viral, we have herpes. Fungal, we have aspergillus. We can also have candida. And in terms of reactive, we have erythematous and seborrhea. So the causes, this is just a repetition where he said we have infective, and infective we have bacteria, and bacteria we have Pseudomonas aeruginosa, and we also have Staphylococcus aureus. We can also have viral, which will have herpes virus. In addition to that, we also fungal, where we have aspergillus and also candida. And where we have reactive, that is erythematous and seborrhea. So otitis externa can be divided or classified according to um, the timeline that it occurs, and we can have acute otitis externa and chronic otitis externa. So acute otitis externa, it's acute, so meaning it occurs less than 2 weeks. And then here it is most commonly by bacteria infection, as you said, most commonly because of which bacteria? Pseudomonas aeruginosa. In addition, you can also have viral, fungal, and non-infectious uh, otitis externa, that is seborrhea and erythema or dermatitis. So chronic otitis externa, this is chronic, that is greater than 2 weeks, and it can be idiopathic, it can be refractory, fungal or bacterial infection, it could be autoimmune, such as in cases of sarcoidosis or amyloidosis. So clinical features of otitis externa, we have itching. So the patient will have itching in the external auditory canal, will have pain in the external auditory canal, and this pain is very severe and sometimes may be the temporomandibular junction pain. So otorrhea, this is the production of discharge from the external auditory canal. There's no discharge, and if it's present, it's very little and scanty, and it is not major. Because the reason behind this is a very key distinction factor between otitis externa and otitis media. So in otitis media, you're going to find discharge or presence of discharge because there are mucoid cells in the medial ear and there are no mucoid cells in the external ear. So the skin does not contain mucus secreting cells. So you can also have deafness. This is when you have conductive loss of hearing, conductive hearing loss. Sorry. So when the canal is completely obstructed by edema, then you can have deafness. So in otoscopy, the findings that you're going to see in otoscopy, you can see erythema. You can see edema, that is, edema, you can see erythema, the redness, or you can see presence of debris. In addition to that, you can also see the tenderness because of the edema obvious and swelling, and it's absent in otitis media. So you need to know the key differences between otitis externa and otitis media. And the tenderness of the tragus and the auricle, these are the hallmarks of otitis externa. Clinical subtypes of otitis externa. So with the first one, we have hepatic otitis externa, and this is when you have an hepatic zoster otitis, or also called Ramsay-Hunt syndrome, and it is a specific form of herpes zoster that present with pre-eruptic lesions, as you can see here. So this is because when, as we say, herpes is for life. So when the herpes zoster is reactivated from the trigeminal or the cervical ganglion, where it goes and stays, then we have herpes zoster oticus or Ramsay-Hunt syndrome. So it is characterized by painful vesicles. The management of this is you give, obvious, herpes is a virus, so you give antiviral drugs. In addition to that, you also give steroid. So the complication of this Ramsay-Hunt syndrome is usually facial nerve palsy. So erythematous or seborrheic otitis externa. This one is usually painless otitis externa, and you can see you can have urea. So localized otitis externa or fuliculosis, this is the inflammation or infection of the hair follicle in the distal external auditory canal. So when you get this, this one you have to know the etiology, as you said, the etiology of otitis externa most commonly is Pseudomonas aeruginosa. However, the etiology of folliculitis or localized otitis externa, it is Staphylococcus aureus. So when you're going to treat, you're going to treat with anti-beta lactamase. So the patient will come in with a history of fever, with a history of previous swimming, and this one is usually very painful. And the reason why it is painful is because the external auditory canal is made out of cartilage, and the cartilage is usually adherent to the skin. So when there's folliculitis, the adherence now will cause, because there's now swelling and already the cartilage is adherent to the skin, then it will cause a lot of pain. So as you can see in the following picture. So in otitis externa, we said is the inflammation of the external auditory canal. But in this case, it's only one part that is inflamed. And this is why we call it folliculitis. As we have said it is fever, history of swimming pool, and it is very, very painful. So next is otomyosis or fungal infection. And this is, as I said, fungal infection can cause otitis externa, and the most common one is Aspergillus or Candida species. The risk factors is immunosuppression, HIV, and including HIV and AIDS, diabetes mellitus. In addition to that, this is long use of antibiotics therapy, because most this antibiotics therapy that we use in the ear usually contains steroids. And what do steroids do in long term? Steroids in long term usually suppress the immunity. And then humid, and those more common those who take antibiotics for a long time, as I stated before. So this one is less painful and more itchy, and the patient will come in with no history of fever in comparison to bacterial infection, which usually have fever. So management is sanction, then antifungal medication. So as you can see, I said there are two types etiology in terms of fungal verticosis, and the most one is the aspergillus. And you can see this is the appearance of the aspergillus, and you can see that you have the hyphae, and this is the candida in terms of appearance. So bullous meningitis. Bullous means it's a fluid-filled blister, as you can observe here. And the location of this blister, just from the name meningitis, which is the inflammation of the tympanic membrane. So let's look what it has. This is inflammatory condition that involves the lateral surface of the tympanic membrane and the medial portion of the external auditory canal. So next, it is typically occurs in associated with upper respiratory infection, and it's more common in the winter. So the patient will come and tell you, so this is occurred after I had an upper respiratory infection. And then the clinical manifestation, we can have severe otoralgia. This is severe painful pain in the ear. We can have seranguinous otorrhea. This is discharge and hearing loss. So the treatment includes analgesia, topical antibiotics, steroids to prevent the bacteria superinfection. And then the hallmark of this, when you do an otoscopy, you will see a bulla over the tympanic membrane and the medial canal with serous or seranguinous fluid, as mentioned before. The next, this is diffuse otitis externa. This is what most people mean by otitis externa. So this is when you have general narrowing of the canal, and the canal will close, and therefore you won't be able to pass anything. And this is when you can have conductive hearing loss, as is mentioned before. And this is just the thing. So where you have inflammation of the external auditory canal, and then you have infection, inflammation, and then you have edema, and then it closes. So the management of otitis externa, this is applicable to all clinical types, but kindly realize that local otitis externa is caused by Staphylococcus aureus, and more preferably we treat it by beta lactamase. However, it can also be treated by ciprofloxacin, which also covers it. So in mild cases, you are going to have ear canal cleaning. In addition to that, you remove the debris and allow penetration of medication. So the topical antibiotics that we give, as I've mentioned before, that acute otitis externa, the most common bacteria causing it is Pseudomonas aeruginosa. So when you are given antibiotics, they have to cover Pseudomonas aeruginosa, and the antibiotics that cover is mostly ciprofloxacin or of olofloxacin ear drops. In addition to that, you can also give neomycin, polymyxin B, and hydrocortisone drops. However, usually avoid this if you have perforated eardrum. And the reason behind is this drug. Neomycin is ototoxic. So the next pain management, obviously the patient will come with autorrhea, so you give them NSAID and including Brufen. So moderate to severe cases, you can switch the medication to oral antibiotics if the infection has spread to beyond the ear, if the infection has spread beyond the ear canal. In addition to that, the medication that you're going to give is just fluoroquinolones, that is ciprofloxacin ear drops. If there's not spread, if it has spread, that you give oral antibiotics. You also need to do a ear wick, and the ear wicks for severe swelling where already we have an obstruction, and this is to allow medication delivery. So the prevention is to keep your ears dry. This is prevention. This is use of earplugs when swimming, avoid insertion of objects such as Q-tips into the ear, use of acidic ear drops such as acetic acid after swimming to prevent bacterial growth, and manage underlying conditions such as eczema. So in case of we have fungal infection of the otitis externa, we say the most common one is aspergillus. We give antifungal drops or cream. The hepatic one, we said we give acyclovir if less than 3 days, and then steroid you also give them to reduce inflammation. So the complication, you can also have prolonged otitis externa. You can have tympanic membrane perforation. This is the tympanic membrane perforation, which you'll see in otoscopy. You also have hearing loss, which most of the time is usually temporary, and cellulitis. Necrotizing otitis externa, which is this a very good, which I've already made a video about it. In diabetes, this is most commonly in diabetes patients and immunocompromised patients.